Welcome back, everyone. It is time to continue our morning's presentation on health literacy, and we're going to start focusing in a little bit more specifically on medications right now. I would like to take a moment to just reintroduce our featured presenter for this segment. We are super fortunate to have all the way from the state of Wisconsin today, Bhumi Khambholja, who joins us from out in Madison at Wisconsin Health Literacy, where she is a project manager on this realm as well as a pharmacist. Bhumi, take it away, my friend.
Thank you so much, Paul. Thanks for having me. I will be talking a little bit more about health literacy and medication directions and reiterating some of the information that Cliff already went over. And so, like he mentioned, there are a lot of phrases and terms that are used as part of standard practice that are not always understood by patients. And there is also research that shows that patients do misinterpret common medication directions. So this is one of those studies. This is the study that Cliff mentioned earlier. And in this study, 395 patients at primary care clinics in underserved areas were shown 5 different medication labels and asked, how would you take this medicine? And their responses were rated accurate if they could correctly state the dosage, the timing of when to take the medication, and the duration. And what was found is that 46% of patients misunderstood directions on one or more prescription label. And separately, the study also looked at the difference between the ability of patients to correctly read directions versus being able to correctly demonstrate how to take the medication. So on the chart here, you can see that large difference in the low literacy group, where 71% of patients with low literacy could read the instructions correctly, but only 35% could demonstrate how to take the medication correctly. So one strategy to improve understanding is to simplify. And you can see a list of common terms that may be used in pharmacy practice here. And Cliff talked a lot about jargon, so I won't spend too much time on this. But the words that are listed here are real-world examples that have caused confusion for patients. So, for example, instead of saying route of administration, for route of administration, instead of saying subcutaneously, you could just say under the skin. Instead of using medical terms, use just some more common everyday terms, and thinking about how they can be simplified. And also, as Cliff mentioned, sometimes healthcare terms or acronyms cannot be easily simplified. So you just have to explain what that term means, especially when a patient might need to know that terminology, either medical terms or even health insurance terms. And I do want to recognize that it is difficult to do that. Once you've learned the language of healthcare through many years of education and training, you use those terms with coworkers. It can be difficult to simplify, especially when you're talking about a topic that you don't commonly talk about. So usually the more practice you have in a specific field, the better you are at breaking down complex health information. So there are some resources listed here that can be used to look up clearer definitions of health-related terms. The University of Michigan Plain Language Dictionary has simplified medical terms. The United Health Group resource has many health insurance terms, and the CDC dictionary includes public health terms. So practicing ways to simplify common counseling points is useful, or keeping a list of commonly used medical terms in your practice with a simplified alternative can also help you adopt this practice. Another strategy is to be as explicit as possible to help prevent confusion, decrease misinterpretation, and make information more actionable, because we want patients to take action to protect their health ultimately. So providing clear timeframes, quantities, durations, or frequencies can help patients take their medication correctly. So for example, take 1 tablet by mouth with food is commonly used, but does that mean right before eating, after eating, or is 2 hours after eating okay? Other explanations are quantity related, where providing quantities and additional details can be helpful because terms such as plenty or small mean different things to different people. And terms used to describe when to take medication can also be misinterpreted. So with as needed medication, communicating how long to wait in between doses and the maximum amount per day can help prevent errors. And even with something simple like take 1 tablet 1 time a day, patients can sometimes misinterpret those directions. So for example, with directions that say take 1 tablet 2 times a day, somebody could take 1 tablet and then 2 hours later take another tablet, which is still 2 times a day, but not the intended way that the medication should be taken. And prescription labels are really the most tangible resource patients have about their prescription medication. So like Cliff mentioned, there's a lot of information for patients to remember. So the prescription label is a tool to help patients find out information or remember information they were told by a pharmacist. So it's important that it is as easy as possible for patients to find and use the information on prescription labels. It's estimated that about 90 million adults in the US have trouble understanding and acting on information on prescription labels. And so due to this issue, the United States Pharmacopoeia released standards to make prescription labels more readable and understandable and make them more patient-centered. Some of the recommendations are listed here. They recommended emphasizing information important to patients first on the label. So for example, having the patient name, the medication name, and the directions first. Improving readability as much as possible by using sentence case and numerals instead of spelled out numbers. High contrast print, larger font, more white space, and horizontal text. And using clearer directions, including the purpose for the medication where appropriate. So you wouldn't want to include sensitive health information on the label. Simplified auxiliary information, and also addressing limited English proficiency by providing directions in the patient's preferred language. And I know that Oregon is pretty advanced in this area compared to other states. And then lastly, addressing visual impairment. So the use of what's called Universal Medication Schedule Directions, or UMS directions, has been proposed as a way to decrease misinterpretations of when to take medication. They use health literacy best practices, and they use morning, noon, evening, and bedtime timeframes. And they also use numerals instead of spelled out numbers for whole quantities. So some examples are listed here. Instead of saying take 1 tablet by mouth daily, you could say either take 1 tablet by mouth in the morning or 1 tablet by mouth at bedtime. They were created after the Institute of Medicine, which is now the National Academy of Medicine, called for explicit and standardized medication directions. They identified poor comprehension of prescription information as a root cause of adverse drug events and medication errors. And they have been tested in 5 languages other than English. They have been shown to decrease misinterpretations, and they also simplify drug regimens for patients. So the picture here shows how 4 different patients organize a drug regimen throughout the day. Some people may take their medicine on the hour and not know if they're able to take their medication with another one that they're on. And so it results in kind of a complicated drug regimen, which is difficult to stick to. So in the first column, the regimen is organized using the Universal Medication Schedule format, which is much easier to follow. And what this does is that it just makes taking medication more practical for patients. So improving understanding and simplifying drug regimens both contribute to patients being able to take their medication correctly and consistently. And research has shown that UMS directions are most impactful for patients who take medication more than once a day, have low literacy, and are over 65 years old. So I'm going to go over some of the comprehension-related studies here. This study evaluated the understanding of medication directions in 359 patients from primary care clinics. Understanding was measured through patient interview. Correct interpretation was 61% for times per day directions and 89% for UMS directions. So this study found that patients were significantly more likely to understand UMS directions compared to both times per day directions or hourly directions. And another study looked at the impact of both having patient-centered prescription labels and UMS directions in 500 patients in primary care clinics. It found that correct interpretation was 77% for 2 times a day directions compared to 84% for UMS format directions. And then if we look at 3 times a day directions here, correct understanding was 44% compared to 91% for UMS format directions. So there are usually multiple strategies that are needed to address adherence. And using clearer directions without jargon and using the UMS format is just an additional strategy to address non-adherence. It decreases the demands on patients and makes it easier to follow their drug regimens, similarly to the way that decreased cost, compliance packaging, reminders, and synchronized medication fills make taking medication more practical and easier for patients. There is also some additional research being done on UMS directions. There is a study that is assessing the impact on blood pressure, A1C, and LDL in patients with diabetes. There is also an expansion of UMS that's been proposed to create clearer directions for opioid medications. And this is being studied to evaluate the impact on patient understanding and safer opioid use. The approach is a take, wait, stop approach to opioid prescribing, where the directions, for example, would say, take 1 tablet, wait 4 hours before taking again. and do not take more than 6 tablets in a day. So using UMS directions when prescribing helps patients remember when to take medication because, like Cliff talked about, it's difficult to remember every instruction that you are given when you're in the healthcare system. And UMS medications are from maintenance medications with standard dosing. Some medications should be taken at bedtime. So the ones that cause drowsiness or dizziness should be taken at bedtime instead of in the morning. And then for some medications, it's more appropriate for the last dose to be taken in the evening rather than bedtime, such as medications that are taken around meals or ones that interfere with sleep. So here are some other applications of how UMS directions are used, other than during prescribing or when verbally talking to a patient about their medication directions. They have been used to create medication schedules at discharge, in bubble packaging, and then pictograms have also been incorporated into medication labels. So with that, I will turn it over to Cliff again, and he will talk about some electronic health record issues.
Oh, thank you so much. Okay, that was great. I'm such a giant fan of the universal medication schedule. And I just was thinking as you were saying that, Bhumi, that I have a patient who very recently was having had 2 emergency room visits for an asthma flare up, 2 back to back. And when I finally saw him in the clinic for the follow up, and I was talking to him about his inhalers, I couldn't understand what could be going wrong. We hadn't changed anything. He was taking his inhalers as prescribed. He didn't have any signs of infection. There was nothing that explained these flare-ups. And then I discovered that the way that the prescriptions had been written was he was using a control inhaler, like an inhaled steroid, that said the label said 1 puff into lungs twice daily. And he was like, yes, I'm doing that. Come to find out that for him, daily meant daytime. And so after it got dark, that was no longer daily. So he was doing his 2 puffs only during the daylight hours, and he was missing a large chunk of the night when for his inhalers. And so it just points out this idea that the universal medication schedule is so much less likely to be misinterpreted. And the data that you showed are staggering in terms of the difference in ability to correctly interpret the use when we use the universal medication schedule. So with that being said, I want to point out how difficult it is actually to, as a prescriber, to use the universal medication schedule, given the current tools that we have. And I'm hoping that our conversation then can take this on a little bit, and we can start to think about ways that folks at CareOregon can leverage influence in the system to help make this better for all of us. So I use our system, in our healthcare system at OHSU, we use Epic, like probably most large systems in the country are currently using, if they're using an electronic health record, which most are now. And Epic kind of dictates our ability to prescribe medications, right? Because they're no longer written out anymore. They're done through this computerized system. Essentially, one of the main issues for us is that whatever the person who's entering the prescription into the system puts in is going to get spit out on the other end in terms of what the instructions are going to look like. So this is a screenshot of from a a list of medications from a real patient in a inpatient hospital setting. And what I'm showing you here is just the fact that the way that the clinician who entered this person's prescription information, the way they put it in using their usual shorthand that we use, is going to spit out medication instructions to the patient that look kind of equally bad. So in this case, you can see that it was entered in this medication, albuterol inhaler, 4 puffs, PO Q4H PRN, right? PO meaning by mouth, Q meaning every, 4H meaning every 4 hours, PRN meaning as needed. So if we were to print this person's discharge summary, it would say use your albuterol PO Q4H PRN. Now, fortunately, we fixed that before we discharged this person. But we can see other examples here. Once daily, right? Bhumi already told us about this. This is not, once daily is not in the universal medication schedule model, right? Because it can be so interpreted in so many different ways. Same with POBID, POQD, every 8 hours, in fact. Interestingly, in some of the data that one study that Bhumi was showing, where they gave a variety of ways of writing the prescriptions, when they said take a medication 3 times daily, people did pretty badly on interpreting that. But when they changed that and they said, well, let's make it very specific, where it said take it every 8 hours, people actually did worse on interpreting that. And the reason why, of course, is that both of these versions, take it 3 times daily and take it every 8 hours, are math problems. These are numeracy problems, and they're hard for people to solve. But we don't recognize that because we kind of live and breathe this kind of language, and our numeracy skills in healthcare tend to be quite a bit higher. So that universal medication schedule, which says morning, afternoon, and evening, takes away the math, right? And so it makes it much easier. And you see that in those data that she shared with us. Now, if we print out this person's visit summary, this isn't the same person, but if we print out a visit summary using this kind of system, we're going to get these sort of non-helpful directions, right? It's going to say 2 times daily, and that's going to we're going to send that person home with that, and they're going to need to interpret that on their own. And we know from studies that they're going to interpret it in ways that aren't going to give them the full benefit necessarily. So when I'm writing prescriptions, I'm literally going in and trying to, every single time I'm writing a prescription, I'm trying to go into the system and do some sort of a workaround to put it into the universal medication schedule format for my patients. And it takes extra work. And I'm actually the only person I know at all of OHSU who is doing this. And I would really like to see a system that took care of this for us, so we didn't have to try to advocate for the prescribers doing extra work, but it's hard to adopt new practices, and they're confusing and they're clunky. So I'm just going to show you what I do, just so you can see what kind of a workaround I've created for myself, and then you can recognize how we need to change that for others. So I'll write a prescription here. Let's say we're trying to prescribe metformin 1,000 milligram tablets for a patient. So I'll enter metformin into Epic, and it'll bring up an automatic instruction that says take 1 tablet by mouth 2 times daily. And we already know that that's not going to be the way I want my prescription to show. I want to use that universal medication schedule. So I want it to say every morning and every evening with food or something like that. So I'm going to go up here and I'm going to click on this use free text button, which is going to erase that pre-populated instruction. It's going to give me a blank space now. And I know that at OHSU, we've developed what we call these dot phrases. So I can enter this thing that says .bid for twice daily. And when I put that in, our system has been trained to change that over to every morning and every evening. But no other providers that I know of even know that exists, and they certainly don't use it. But for me, I put that in, and then I can put in a reason for the prescription, diabetes. And now when I print out my visit summary, it's going to be in the format that I want it to be in, right? Whatever, every morning, every evening, using that universal medication schedule. which I know is so much more helpful for my patients. But that's a really clunky, awful kind of workaround. And it's very difficult for me to try to teach that to anybody because nobody wants to try to remember to do that. And so I really need a systems change, right? We really just need Epic to make it, to adopt more like a universal medication schedule default. And if we did that, I think we would really start to see incredible differences in adherence, probably a lot less accidental or adverse reactions to overdosing accidentally, et cetera. So that's that. I'm going to stop with that, and I'm going to hand it back to you, Paul. And I'm really excited to hear what you all, what your thoughts are, questions, comments, where you think CareOregon can make an impact here, and what's the next step for us.